everyone. Welcome to How COVID-19 Has Exacerbated Healthcare Disparities Among BIPOC. For several years during the month of July, Mental Health America has created campaigns to bring awareness to the unique struggles that underrepresented groups face in regard to mental illness in the United States. Our efforts aim to extend and honor the work of B.B. Moore Campbell, a mental health advocate, author, and speaker. In June 2008, July was officially recognized by Congress as B.B. Moore Campbell National Minority Mental Health Awareness Month. As we continue to honor her work, we also recognize that people and language evolve. So MHA has chosen to remove the word minority from our materials. Instead, we are using a different designation, BIPOC, that we believe more fairly honors and distinguishes the experience of Black, Indigenous, and people of color. Moving forward, MHA will refer to her efforts in July as centered around BIPOC Mental Health Month. If you want to learn more about BIPOC Mental Health Month or B.B. Moore Campbell, please visit mhanational.org/BIPOC. Today's speakers are, one second. Sorry about that. Lost my stuff. Oh no. I'm so sorry. My computer froze. I'm pulling this back up. Okay. Our speakers today are Michelle Ogunwal, MD, is a health disparity researcher, social epidemiologist, and general internal medicine physician specializing in the care of women with chronic mental health conditions. She has advanced training in quality improvement in patient safety science. Her research is focused on racial disparities in maternal health outcomes among African American women. Specifically, she is interested in four main topics: the role of the general internist in optimizing chronic medical conditions in the preconception period, postpartum chronic disease and long-term health outcomes related to complications of pregnancy, particularly for women with gestational diabetes, hypertension, hypertensive disorders of pregnancy, or excessive gestational weight, African American women's experience with the healthcare system, specifically their experiences of racial discrimination and barriers to primary care, follow-up after pregnancy, and creating equitable, community-driven quality improvement interventions around transition of care from obstetricians to primary care for racial and ethnic minorities who experience medically complicated pregnancies. Dr. Ogunwal has an active role in medical education. She serves on the Association of American Medical Colleges Quality Improvement and Patient Safety Competencies Working Group, where she worked extensively on the health and healthcare equity domain of the recently published Quality Improvement and Patient Safety Education Competencies. She participates in student engagement around implicit bias mitigation in clinical care and patient-centered communication. She actively works to improve the diversity of the healthcare workforce by participating in recruitment and application review for new medical students, residents, and faculty. Our other speaker today is Danica Love Brown. She is a citizen of the Choctaw Nation of Oklahoma, born and raised in northern New Mexico. She currently is the behavioral health manager at the Northwest Portland Area Indian Health Board and has worked as a mental health and substance abuse counselor, social worker, and youth advocate for over 20 years. She has a history of working in the areas of prevention, drug and alcohol and mental health treatment, community and restorative justice, and sexual health with Native American and adjudicated youth, families, and women. She specializes in working with culturally and socioeconomically diverse populations and tribal communities, utilizing a trauma-informed care framework. Danica is an Indigenous Wellness Research Institute iSmart Fellow alumni, Council of Social Work Education Minority Fellowship Program fellow alumni, and Northwest Native American Research Center for Health fellow alumni. Her research is focused on Indigenous ways of knowing and decolonizing methodologies to address historical trauma and racial disparities in tribal communities, and she loves puppies. We will be recording this webinar and sharing the recording and slides following the event. We do not offer continuing education credits. However, we are able to provide you with a certificate of attendance, and the information for that will be available on the last slide. With that, I'm going to hand it over to our presenters.
Thank you so much for that introduction. This is Michelle Agunoli speaking first, and just one small technical thing. Could you give me control of this, the actual presentation, so I can advance slides, or?
I'm working on that right now.
Okay. Well, while she's working on that, and if not, I can just tell you to advance slides. I think we've all had to become more flexible during this time working with technology. But I just wanted to reiterate kind of some of the things that were touched upon. I am an internist, but during this time period, I've been working in the hospital as a hospitalist, and working a lot during this crisis. And I'm really just very excited to be here to talk about this topic with you all who are here virtually. This is something that's really important in our public health world, and I'm glad to be able to share some knowledge and hopefully answer some questions. So I
don't see how to give you control, unfortunately, so I'll have to advance the slides manually. I'm sorry.
Was I talking that time?
Sorry, you got cut off somehow.
No, that's okay. We'll just go ahead and get started, just to make sure the other presenter also has time. And if we get it figured out in full screen mode, great. So I'll just go over briefly some of the goals of this session. So I wanted to give an overview and describe the racial disparities in COVID-19 health outcomes, evaluate drivers of COVID-19 related health and healthcare disparities, and then discuss some emerging information about COVID-19 and really the importance of continued vigilance during this time. I think can you go to the next slide?
I'm sorry, I'm not sure why it's not advancing on your side. It's showing up on mine as having advanced. There we go. I guess I'll just have to scroll more manually.
So I just put this slide in as there. Perfect, great. Yeah, I think people are asking for it to be in slideshow view if possible, but if not, I think this is better than it was before. So I just wanted to start with this kind of quote from an op-ed actually from one of my colleagues at Hopkins. This is a piece from The Atlantic called "The Virus Will Win." And one of the last lines of that piece was that pandemics reveal the true state of our society, and ours has come up badly wanting. And I think what Yasha Monk meant by that is that, oh, okay, sorry. It looks like there's a couple of, I don't think people are able to see the slides at all, Madeline. Yeah, I could be wrong, but that's what I'm seeing in the chat window. Okay, so some people can see them. Okay, great, thank you. Awesome. Many people are seeing the slides. Thank you guys for your patience. But my point in starting with that quote is really that this pandemic has revealed, I think, in our society that COVID-19 is really a magnifier of social inequality, and that's really what I'll try to focus this discussion on. Next slide, please. Yes. So this is actually a roadmap from the American Journal of Public Health, a paper that was published in 2006. And it's the 3 phases of disparities research. Great. In the 3 phases of disparities research, something that health disparities researchers think about in terms of solving disparities is how are we going to get that done? And so this is an agenda that I often use, and I'll use it to kind of guide our discussion. So the first phase is really to detect. So you have to know that there's a disparity there. And after you detect, you have to understand, and then finally you can move on to reducing. So going to the first step, which is detecting. Can you advance the slide, please?
You actually have control of the computer now, so you'll have to do that. It's being very finicky, apparently.
Oh, okay, great. Yeah, I do have control. Great. So this is just a slide that shows, like, as we are trying to detect that early on in this pandemic, we actually had a lot of missing data. So many states were missing race ethnicity data and they weren't collecting it at all. And so this is just kind of a map of that. Now that we have actually started collecting some data, these are maps from actually from Johns Hopkins, and now that we started collecting some data, this is just showing which states are still missing data. So to date, we actually only have 4 states that are reporting race ethnicity data in the testing category of COVID-19. We're doing much better with confirmed cases. So now currently 47 states are actually showing data on race ethnicity in terms of confirmed COVID cases. And then again, 45 states are now actually collecting that data in terms of the death category. So while we have improved, I think this is great, but one of the things I will mention briefly is that there are still certain vulnerable populations for which we don't have as robust information. That includes pregnant populations, people who are in prison as well. And so this is going to kind of be an ongoing theme, I think, in health disparities research, is that we can't change what we don't measure. And that's why the importance of having this data continues to be, I think, pressed upon by people who do this work. But even still, with the data that we do have, and it continues to pour in, one of the things that we have found time and time again is that Black and Indigenous and Latino populations are experiencing disproportionate disparities with relationship to COVID-19. And so this data was from the end of June, but it said overall COVID-19 mortality rates for Black Americans is 2.3 times as high as it is for white and Asians. And that number is similar for our Latinx population. And this slide is just showing just kind of another big picture view of the same thing. We see here again that the Black population really is having a much larger disparity compared to other groups, and followed by Indigenous and then our Latinx population. And so that's kind of just like a big picture overview, and you may have seen some of this information coming out in the media. But really moving on to what I wanted to focus a bulk of this discussion is really understanding these disparities. So now that we've identified that they're disproportionately impacting certain groups of people, we need to understand what's going on here. So this is one thing that you may have heard, and that is related to just the burden of chronic disease. And so this slide just shows data that was collected actually in 2002 on the left, and it just shows, again, when we look at the racial ethnic breakdown, that African American and Latino populations are much more likely to have any chronic condition if they're older. And to the right of that, this is more recent data in 2018. This was in DC. But similarly, you can see kind of the burden of disease and how it falls across the racial and ethnic groups. And so asthma at the very top, you can see that a large proportion of people who suffer from asthma are Black. And you can see as you go down through these chronic conditions that disparity maintains. And one of the reasons that's important is because we found with COVID-19 that there's a higher proportion of patients who have chronic conditions. And so this slide is showing that really across all patient groups with COVID-19, 89% of them had at least one chronic condition, and 94% of them had at least one chronic condition if they were age 65 and older. And so you can kind of put together that some of these racial and ethnic disparities may be due or attributed to the burden of chronic disease that is different across racial and ethnic groups. But I wanted to talk a little bit more about that. It's not just the chronic diseases are different between racial and ethnic groups. There's certain drivers of those differences. And this model from the Kaiser Foundation shows something called the social determinants of health. And it talks about how their social and economic factors really drive health outcomes. Things like your socioeconomic status, or how much money you make, if you're employed, if you have insurance, the neighborhood where you live, and if that neighborhood is safe, is it filled with toxins in that neighborhood? Is it walkable? And then of course things like education and food, and as well as like your community and access to the healthcare system. And then right in the middle of all that, we see racism and discrimination. And I'm actually going to dive a little bit more into this piece in particular, just given the current times, and really start to think about how racism and discrimination really underpins many of the other social and economic drivers of health outcomes that we see across populations. So this is like an iceberg that we kind of looked at and think about racism as an iceberg. And so you see at the very top on the iceberg on your left, you kind of see the events and patterns that we see out in the world, whether or not that is the fact that people have different chronic disease levels by race and ethnicity. But then below the surface, which may not always be as seen, are those structures. And that's really what causes the pattern to be maintained. And then if you go to the right, this is another iceberg that dives in a little bit more deeply. Again, you look on top of that iceberg, you see some of the overt things that we can actually see in our societies. So maybe that's hate crime, that's poor treatment that people experience. But when you look below the waterline, you see people's implicit attitudes, that things that you can't always see. And then you see those structural components like segregation, racial ideologies, and some of these institutional policies and practices. And I want to go in a little bit more into some of these structures. Now, this is a slide from around 2007. They published this more recently in Forbes, and it shows the racial and wealth inequality in the United States. And so you can see that among white Americans, there's just a higher level of wealth. And I show this to just kind of reinforce the idea that this is what kind of the structural forces look like in our society. And they date back to many, many generations before, but it puts different groups at positions of advantage versus disadvantage. And that may show up in a lot of different ways. So when you look at Black Americans specifically, you can see that there's a higher proportion of disenfranchisement of the Black voting population. You see that Blacks are 2.5 more times more likely than whites to be killed by police. You see that there's less kind of intergenerational upward mobility for Black children. And then when we look at sentencing in the criminal justice system, sorry, the slide is a little small, we see that compared to compared to white people, you see that there actually is a disparity in the sentencing where Black and Latino populations actually have increased sentences for the same crime, and they have longer sentence length. And so these are all examples just of kind of the structures that are built into our society that impact different racial and ethnic groups and the way that they can access resources. And I just will point out that one of the things I wanted to mention is a lot of these things, like I said, are very deeply embedded in our society. I didn't put a slide in here, but one thing that we talk about often is something called redlining or residential segregation, which is something that occurred many, many years ago, but we're still really seeing some of the consequences of that. And for those who aren't as familiar with that, this is kind of the way in which the government can create resources for different communities and put certain communities in different locations in a country. And so when redlining was going on, we see that as a result, even today, we really see that certain groups, racial and ethnic groups, are really packed into certain areas in a city, and that their health outcomes are really defined by their zip code more than anything else. And so we really see the remnants of the legacy of some of those policies really even today. And kind of bringing this back to present day, I like this slide because it shows kind of COVID-19. It shows the risk of COVID-19 by your occupational exposure and your income. And one of the other drivers that we really think about as to why these disparities were happening, which you may have heard, is that racial and ethnic minority groups are much more likely to be in low income service industries. And if you look kind of at the left side and blue side of this picture, you really see that that's actually where you start to have the higher risk in some of those low income service industry jobs and professions. And so that's one reason that they may have increased susceptibility to catching the virus. And then the other part goes really to the wealth conversation that I started to have. Well, if you have less economic reserve, then you really do have to go to work, and you're not as able to socially distance, and then you're much more likely to have households with an increased number of people, and so you're in tighter quarters, and all of these things contribute to viral spread. And so when you start to piece together all of those things, you recognize that there are certain groups that are inherently going to be at higher risk for getting this virus. And if you layer that on top of the kind of chronic medical comorbidities that I talked about, you get what we see today, which is this much higher risk in our Black and Latinx and Indigenous Native American populations. Now, again, that was kind of a very brief overview of some of those structural barriers, but going back kind of to the top of the iceberg, I wanted to kind of touch briefly on the overt experiences of racism that have all, I think, been magnified in this pandemic, probably most recently in terms of the George Floyd incident. And, after that incident happened, we saw a large number of people coming to the streets in protest. And I think this whole situation, the magnification of the social inequality on top of kind of this really horrific but very overt picture of racism in this country, it just kind of coalesced, and it was the perfect storm. And it forced us, as I think, public health researchers to start publicly acknowledging really the impact of racism on health. And what we do know is it's not just that people are being killed by law enforcement disproportionately, but there's research to suggest that racism actually makes people sick. Within the Black Black community specifically, who are having really disproportionate disparities in COVID-19. We know that racism, even those small indignities, which sometimes are called microaggressions, are related to increased rates of low birth weight infants, higher blood pressure, and even early mortality. And so it's not just that people are experiencing racism and they're unhappy with it. It's truly affecting their health. But I want to shift gears a little bit, just to, again, it's a quick overview, and happy to take questions about any of those things a little bit later. But I wanted to talk about the fact that the pandemic isn't over, and really use this opportunity to emphasize that point. So you may have seen in the news recently that there's been an increase in cases in certain states across the country. I actually pulled this morning, so that's why I was still working. But the New York Times posted kind of the world's worst outbreaks, and across the entire world, we see that Arizona, Florida, and South Carolina are really the 3 states that are having the worst outbreak at this time. And it really is just kind of confirming the fact that the US really isn't like other developed nations. So we kind of see these other developed countries and where their COVID case counts are going. Theirs are in Europe, Canada, and Japan, they're really going down. But in the United States, we see that the cases are actually on the rise. And I wanted to pull this picture in just to kind of talk about the fact that at the beginning of this pandemic, what we really had to go off is information from China. And one of the things that was published, which is still true, is that COVID-19 was really a disease of the older people had much higher mortality. And that's, that has been the case. But I think that sometimes people hear this, some of the misconceptions I've heard is that people hear this information and they think that they're not at risk if they're not older and they don't have several chronic conditions. But I would like to argue that the United States is different from China for many reasons. And here we see kind of a new trend that's going on in the United States. This is data from South Carolina that really shows, as we're shifting in this virus, that actually more and more young people are actually being infected with this virus. So we've seen kind of a different pattern in the United States, potentially attributable to the fact that we have a higher chronic disease burden, and we also have a younger population that has chronic disease. But nevertheless, if there's anybody who had that misconception that just because you're young that you can't be infected with COVID and actually have severe morbidity and potentially even mortality, that is not the case. So I just wanted to dispel that myth. And then I wanted to talk a little bit about the African American population specifically. This is some CDC data that says that young African Americans are really living with diseases more common at older ages. So that kind of amplifies that idea. And so really the big picture is that there really is a long road ahead, and it's very, very important to stay vigilant. I mean, I go out and I talk to communities and I see that people continue to have this idea that we're almost through this, but the truth is that we're still in the middle of this. And me and my colleagues actually published a piece a couple of months ago comparing the current pandemic to the influenza pandemic of 1918. And, that pandemic actually had 3 different waves, and it wasn't even in the first wave that they had the most severe number of morbidity and mortality. And so that's why I'm always reminding people to stay vigilant. And even now, we are seeing in some states, the number of deaths are declining, but in some states, like my home state of Texas, we are seeing the case numbers are just continuing to rise, and we're still trying to figure out what it all means. And the other point is, our data that we collect there's usually a lag time between the data that we collect and then what you actually see, like that Johns Hopkins, for example, is publishing. And so we often see like the after effects of certain things like Memorial Day or 4th of July or anything like that, and people gathering long after. I had 2 more slides that I was trying to advance, but I think my control got taken away. So anyway, take-home messages. So just racial disparities in COVID-19 exist, and Black, Indigenous, and other people of color are really at highest risk for both infection and death. The root cause of these racial disparities are really rooted in social and structural inequity that have been going on for years and years and years. And really the pandemic is not over. So please wear a mask, wash your hands, and avoid large gatherings if you can. I think I had one more slide, but I can just, I wanted to show this because this issue of the mask is something that I just want to make sure really hits home. This is actually the mayor in Atlanta who talked about how she tested positive for COVID-19 and she really hasn't had symptoms. And so again, I try to tell people that even if you don't feel bad, it's really important to wear a mask, and whatever image you need to see to make sure you understand that. I like the one that I'm showing here that really shows what happens when you're symptomatic, you're infected and asymptomatic, which would be like the mayor. So she was positive, but she had no symptoms. So you can still spread this to healthy people. But when both parties wear masks, it really reduces that risk. And so I can't really harp on that any more than I can. I see a lot of people wearing masks. I see them wearing masks improperly, but it's one of the few things we can do. And I will also say that in terms of kind of the structural inequities, I try to make it a point that to say that people who are experiencing disparities and discrimination and racism, the onus is not on that population to create changes in this country. I think the onus is on what we would call non-marginalized groups to be allies and to really think about that. Those things require policy shifts. But the one thing that I think, to end kind of on a positive note, one thing that we do know about this pandemic is that this country is capable in some ways of changing rapidly. I've seen that with the way Medicaid has expanded to create access for telemedicine. Those kinds of things that weren't there, things that we thought were immovable, really aren't. And so knowing that our country is capable of making change gives me some hope. But I think that these policies really have to be addressed in order to actually get at the structural inequities that we see. But in the meantime, you can also encourage people to wear a mask. And I tell the populations who are most at risk that, hey, this is going on in our communities, and we have to spread the word within our communities that this is important and people are dying, and all of us need to be as vigilant as possible. I think maybe I had 1 or 2 more slides, but that's fine. I think that was my other slide. I have a slide of masks coming down from the sky as if they're money falling from the sky, and I hope that people will grab at it like it is take that image home and grab at the masks just like that. That was not. Oh, take home message. Sorry. Yeah. Sorry, I'm seeing lots of messages.
Okay, and Dr. Brown, you're up. We'll take questions from everyone at the end.
All right, I'm going to go ahead and just share my slides versus having you share them. So can everyone see my slide?
Yes, you're good.
Okay, great. First and foremost, I want to thank everyone for the work that they're doing to support their communities in this time of crisis and insecurity. In this presentation, I'm going to focus on the multiple intersections of life experiences that impact trauma and the current pandemic and our collective trauma reaction. I'm not going to talk so much about trauma-informed care, I'm just going to talk more about the connection between trauma and our collective experiences. And in the slides, there are some tools that you can use, but I don't think I'll be able to really have time to go through that, but they'll be available for people later on. So my name is Donica Brown. I'm a citizen of the Choctaw Nation. I have a PhD in social work with a focus on healing trauma, intergenerational trauma, and historical trauma. And I'm the behavioral health manager at the Northwest Portland Area Indian Health Board. Let me see. There we go. And so I want to talk a little bit about trauma-informed care, because I think that it's important, but I don't want to go into it too much. You know, when we talk about trauma-informed care, it's really kind of like utilizing this metaphor of placing the oxygen mask on yourself first before you place an oxygen mask on the person next to you. But this model also acknowledges that the systems that we work for have a responsibility to address trauma and understand trauma, particularly with marginalized people, BIPOC people, and not just with the clients that we serve, but also with the staff and administration. Trauma is a complex human condition that impacts people in different ways. And research has shown that our intersectional experiences can impact our responses to stress and crisis. Trauma is connected to our sense of safety, and that includes like our housing and resources, and safety is, and these things are intimately connected. And trauma also impacts the way that we navigate in the world. So what is trauma? Trauma, it is an extraordinary psychological experience, but it's tied to the way to our security and safety and the way that we navigate the world. The source and type of trauma dictate the impact and magnitude of trauma. It's a lived memory or reliving the memory. It's pervasive and ongoing attacks and slights associated with our identity. And an assessment of trauma should be made in the light of clients' cultural life history and BIPOC status. And so there are lots of different kinds of trauma, and I'm not going to go into all of these. I specifically want to talk about complex trauma and historical trauma. Complex trauma describes both a child's exposure to multiple traumatic events, often evasive and interpersonal in nature, and the wide-ranging long-term effects of this exposure. These events are severe and pervasive through abuse and profound neglect. And a study that was conducted in the 1990s with Kaiser Permanente and the Centers for Disease Control, referred to as ACEs, or early childhood exposure, really solidified in our understanding of trauma. So trauma is stored in the limbic system of the brain, which is not generally connected to language. It's that really old part of the brain, the primitive part of our brain. And memory is stored in the cerebral cortex, and that's connected with language. So when we're thinking about trauma health, what we're doing is bringing back the limbic system into health by helping it communicate to the cerebral cortex. And there's lots of skills that we can do to help do that. And like I said, there was a study that was conducted with Kaiser Permanente, the Adverse Childhood Experiences study, that showed that ACEs are common in this country. For example, 28% of the study participants reported physical abuse, and 21% reported sexual abuse. ACEs cluster. Almost 40% of the Kaiser sample reported 2 or more ACEs, and 12.5% experienced 4 or more. The more ACEs that you experience, the higher your mortality rate is, and the more that your life, you experience it in other areas of your life. The other thing is that ACEs have a dose-response relationship to many health problems. And researchers have followed participants over time, discovered that a person's cumulative ACEs score has a strong graded relationship to numerous health and behavioral problems. And then a lot of us do experience what we understand as vicarious trauma or secondary trauma. Care providers, we really need to be aware of that and take care of ourselves. And so the COVID-19 outbreak has the potential to increase stress and anxiety, both because of the fear of contracting the virus, but because of the uncertainty about how the outbreak will affect us socially and economically. And there really is not a real sense of that this is going to be ending anytime soon, and we keep talking about this new normal. And all of that can cause a great deal of stress. And if you already have a history of trauma, this can really exacerbate the trauma. But there are practical steps that we can do to improve our well-being. And what many people are experiencing right now is really around scarcity resource trauma. That's why we were seeing a lot of people in the beginning hoarding food and resources. And so crisis activates the limbic system to kick in our survival system. Lots of hormones are flooding into the brain and our nervous system. Because most of us have not lived through a pandemic, pandemic is not registered in our memory system. So the survival system goes and doesn't know whether to pick fight, flight, or freeze. So our brain cycles through all of these trauma responses to decide which is most beneficial. And this is why we find ourselves moving through a lot of responses and feeling overwhelmed and uncertain about our reactions. And so, you know, fight, flight, and freeze are our ancient survival responses to life-threatening circumstances. Fight can be seen as anger, anxiety, adrenaline rushes, being short with people, in being short with ourselves. Flight can be seen as an overexcitement. I mean, it can also represent itself as anger. You know, we tend to focus on our work and other activities versus, you know, thinking about the pandemic. Freeze can be seen as depression and sadness and ambivalence, not being able to focus on anything, and our executive functioning is compromised. You know, I think a lot of the people that we're seeing who are, you know, really ambivalent, I'll just put it that way, to wearing masks, to me, this is really kind of a freeze response to kind of putting their fingers in their ears and going, blah, 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 blah. I don't want to hear it. I don't want to hear it. It doesn't exist. And that can be viewed as a trauma response. But as we gather new information all the time and constantly, the limbic system again decides we're in danger and cycles through the fight, flight, freeze response. As providers, we are both expected to gather data and interpret the data for our communities, and then this also impacts us. Trauma and fear create detachment, and the antidote to that is attachment and connection. And this pandemic, we're being asked to socially distance, which then impacts our ability to stabilize in crisis, which then impacts our trauma response. So it's a vicious cycle. I want to talk about historical trauma. For many BIPOC people, we're also dealing with another layer of trauma, which is commonly referred to as historical trauma. Historical trauma results from the long-term effects of the oppressive, traumatizing policies, attitudes, and beliefs of the colonizer towards BIPOC people. The lack of resources and opportunities for tribal people or BIPOC people, and the current treatment of BIPOC people in this country. Maria Braveheart Yellowhorse defines historical trauma as a cumulative emotional and psychological wounding over the lifespan and across generations, emanating from massive group trauma. Eduardo Duran refers to this as soul wounding. For tribal people in particular, this is not our first experience with a pandemic. We have survived pandemics prior to this one, and some of them were brought to us intentionally. So it's important that we acknowledge that when tribal people in particular hear things like, we've never seen anything like this before, we're devaluating the experiences of those people in those communities. We also need to understand that tribal communities have an additional layer of trauma. BIPOC communities have an additional layer of trauma that we're experiencing and have no language attached to that experience. So we can and should expect that this is going to exaggerate our trauma responses in this current pandemic. And then with the uprisings that are currently happening as well, this is also impacting our experiences. One of the other things I do want to talk about too with that is that there's some current research that shows that there is an epigenetic transfer of trauma that can happen with historical trauma. My grandfather, who was a tribal member of the Taos Pueblo Indian community, he was a very old man. He died when he was, we think, over 104 years old. His name was Little Joe Gomez. And he always would tell me that the memory of my ancestors is carried on our blood. And what we now understand is that actually is true. That historical trauma impacts the proteins that house our DNA. But what we also are starting to understand is that it's not just historical trauma that's transferred on our DNA, it's also our ancestral wisdom. And I think one of the things that's really important to understand in this pandemic is that, tribal communities have experienced pandemics before, and we've survived pandemics before. We have an ancestral wisdom and memory that helped us to survive that. And I believe that we, as tribal communities, have tools and lessons and skills that can help BIPOC communities to survive this current pandemic. And so I want to look at the time. I'm not going to go too much into this slide, but we do, when we think about what we need to do and to address address trauma within this pandemic, an important part of it is to increase our sense of safety, to stay connected. It's really, really important. And we do have, these social media platforms that can help with that. We need to improve our sense of control and ability to endure, accept circumstances that cannot be changed, and focus on what we can change. Cultivate ways to be more calm, and we need to remain hopeful. It's really, really important. And there are lots of ways that we can practice self-help or self-care when we're in a quarantine. And I'm not going to go into this slide, but I will send the mental health wellness tips for quarantine to the community, or to the organizers of this presentation. One of the most important things that you can do for anyone who's experiencing a trauma response, and this exercise helps bring the limbic system back into communication with our cerebral cortex, is to practice box breathing. And so I just want for a minute to ask everyone to practice this just for a minute, to practice your breathing. You want to exhale through your mouth. Inhale. Hold. So what this does is it brings oxygen up to your brain. It stabilizes your parasympathetic nervous system and helps your different parts of your brain communicate. So I would suggest everyone do this multiple times a day for 2 to 5 minutes. And if you are working with someone who is dysregulated, you can actually practice this with them, and it's very, very helpful. So in summary, I just want to summarize and by saying that, you know, we are living in extraordinary times with much uncertainty and fear. You know, we cannot change the experiences that we're having regarding this pandemic, but we can change our perceptions of our experience and take some steps that we both can individually and collectively survive. As providers, we have the burden of taking care of ourselves, our family, and our communities, and it's imperative that we take care of our individual mental health before we can take care of others. And it's a trauma-informed care protocol to put the oxygen mask on first before we put it on others. It will also help us to practice to understand how trauma impacts our brains and our reaction to this time and place in history. And really, most importantly, that a lot of the historical memory that BIPOC people hold is there. And that we need to look towards those communities on how to survive in this time. And I will close it with that. Thank you.
Thank you both for such great presentations. I'm going to share my screen just so that people can get the information about where to get certificates of attendance. In terms of questions that we've received, one was, does wearing a mask cut off or reduce your oxygen intake, which I think is something a lot of people have heard very mixed messages about?
Yeah, I'm happy to answer that. No, wearing a mask does not reduce your oxygen intake in any appreciable way. I think the other flip side of that is people have been worried about kind of CO2 retention. It's minimal and something that you should be able to, as long as you're healthy, you should be able to get rid of kind of through other metabolic processes. I will say with the caveat that people with something like severe obstructive sleep apnea or other like very chronic lung conditions, I wouldn't recommend like falling asleep with a mask or things like that nature. But overall, I would say that the risk from COVID-19 and potential like adverse outcomes from that kind of are more pressing than the very, very minimal like CO2 that you would even retain from a very properly fitted mask. So.
Great. Another question we got was about what people can do about these racist systems that are in place, because there are so many policies that were meant to address these disparities, such as the Affordable Care Act, and what has actually, you know, changed from that, and what can we be doing to have a more meaningful impact?
Yeah, I guess I think about the answer to that. I think sometimes people wonder from like an individual level, depending on kind of like your sphere of influence, whether you're a provider or you provide other services within the community. And if you are, I guess I would call a group an out group who maybe doesn't share that experience of racism. I think that what it means to be an ally, I think people have kind of asked me that question too. And so I'll speak, I think, to the individual part. I think these communities need people to do more than say like, this is horrific and we're really sorry this is happening. I think that is a first step. But I think whenever you hold positions of power and privilege, you have to use those opportunities to speak up. And also say that, you know, even within like the realm of being a provider, I often try to change my language and say things like, you might be at higher risk of something, not because you're Black or Hispanic or Latino, but because we know some of the structural forces that have gone on within your communities over time lead to X, Y, and Z. So really trying to be really specific in the language, trying to create opportunities as an ally or a person in power, where you see there's opportunities to be had in terms of elevating other people's work who might be within these communities who don't have opportunities to have that work elevated. So whatever your spheres of influence is. And then of course, you know, we talk a lot about voting and making sure that we're voting and you know, holding our leaders accountable and voting for leaders that we think have a similar vision of what it means to be in an equitable society. So, you know, that's, I guess I'll stop there, and happy to send out some other resources. I think the National Medical Association has some great resources they recently put out for people who are interested in having more details of how they can be involved, and just recognizing that, you know, the legacy of racism it's 400 plus years, so it's not something that can be dismantled. I always tell people that as well.
Great, thank you. One question. Oh,
I
yeah.
noticed that there was a question about whether people of color other than Indigenous can experience historical trauma, and yes. The original research that really happened around kind of this idea of historical trauma came out of the work after the Jewish Holocaust. And that was really where the work kind of formally started. A lot of the work that came out of like what historical responses are and the healing of historical trauma came out of South Africa after apartheid, with some work that happened after that. And so absolutely, a lot of the work around historical trauma is framed around Native American experiences. But, you know, there was a person, and I don't recall her name off the top of my head, who does a lot of work around what she calls post-traumatic slave disorder, and which is essentially the historical trauma responses of the ancestors of enslaved people. And so, yes, it's absolutely part of any person who was marginalized and experienced systemic oppression and violence and genocide experience historical trauma.
I think, I was gonna answer, I saw a couple of other questions too, that someone was asking a specific question about diet and genetic makeup and if it contributes to disparities. I will say that, like, one of the things that we've learned around chronic conditions is certainly, actually a study just came out, I think today, about what are the chronic conditions that are actually related to COVID-19, and obesity was one of them, actually even more so than like hypertension. And so I guess in that way, I always think about, of course, our diet plays a role in kind of the obesity epidemic. I'm actually like a plant-based lifestyle medicine kind of doctor, and so I think that food can be medicine in a lot of ways, and what we eat definitely has an impact on our health. And I'll say the other part of that is looking again at the structural racism. We know in communities, in BIPOC communities, that they're much less likely to have access to, you know, grocery stores. They're much more likely to have a higher proportion of corner stores and liquor stores and fast food restaurants. And so some of these choices on diet, and that's why I always caution people to say, well, people need to make better choices. But, you know, the first step in making a better choice is having a better choice to make. And so I certainly think that diet does play a role in health. I think we don't know for sure if certain types of diets, if that's what you were asking, predispose people to COVID-19, because I think we're just in the beginning phases of our research, but we're rapidly working on it. So I hope that answers the question.
And I want to add around the diet that within like tribal or indigenous communities that, you know, it was a part of our genocide where our food sources were taken away from us and then replaced with high carb, high sugar, high fat commodities that continue to impact us. but it's also really intimately tied to our trauma experience. When we're having a trauma response, our brain is actually burning a huge amount of calories. And there's a reason why when we're having a traumatic experience, we crave chocolate cake and not broccoli. People don't become, when they have issues around food, they're not, people don't become addicted, and I'm using my air quotes around that, to broccoli and celery. There are food disorders that are tied to that, but it's a different process. We crave high carb foods when we're in a trauma response because our brain is burning, our bodies are burning a huge amount of calories. And our relationship to food is intimately tied to our historical experiences in this country. And then it's also layered with, I think, what the previous speaker's talking about, with the policies of how food is distributed in this country, and how BIPOC people have a limited access to healthy food as well. And so it's just a complicated issue for sure.
Oh, sorry.
Thank you both so much. And we will be emailing out the slides and recording by the beginning of next week. Thank you, and have a good day.
Thank you.
Thank you all.